In this section, Autonomic Pharmacology 1, we'll be primarily discussing the neuroanatomy of the autonomic nervous system and cholinergic signaling in that system. In the next section, entitled Autonomic Pharmacology, we'll be talking mostly about the cholinergic system. As you're aware, autonomic pharmacology is very important for the control of the autonomic nervous system. That's responsible for automatic or unconscious bodily functions. Controls of this will regulate heart rate, peristalsis, sweating, and so forth. And this can be divided into parasympathetic and sympathetic nervous systems. Neurotransmitters in the autonomic nervous system include many, including acetylcholine and norepinephrine. Most direct transmission from the central nervous system uses acetylcholine, meaning presynaptic neurons will release acetylcholine onto a postsynaptic neuron. Postganglionic parasympathetic neurons will also use acetylcholine, but postganglionic sympathetic neurons will use norepinephrine, except certain sweat glands which will use acetylcholine. It's very important to remember the anatomy of the autonomic nervous system for step 1, and to remember which types of receptors are used at each synapse. This is a simplified diagram for the sympathetic nervous system as well as the parasympathetic nervous system. In the sympathetic nervous system, the preganglionic nerve has its cell body in the central nervous system, whether it's in the brainstem or the brain or in the spinal cord. The preganglionic neuron will release acetylcholine onto a postganglionic neuron that has its cell body in a ganglion, and that ganglion is outside the central nervous system. Acetylcholine is the neurotransmitter that's released each time. The receptors here on the postganglionic neurons are of the nicotinic type. These postganglionic neurons will usually, in the sympathetic nervous system, release norepinephrine onto the target organ. In sweat glands and the sympathetic nervous system, it's acetylcholine that's released. In the adrenal medulla, acetylcholine is released onto the chromaffin cells, which then release mostly epinephrine, but also norepinephrine, into the bloodstream. In the parasympathetic nervous system, we have a cell body that's located in the central nervous system of a preganglionic neuron, and this preganglionic neuron will release acetylcholine onto a postganglionic neuron. This ganglion is usually located in the target organ, and acetylcholine is then released onto that target organ, onto either the heart, smooth muscle, or other types of glands, and usually counteract the effects of the sympathetic nervous system. The neuroanatomy of the autonomic nervous system is very important to remember. Remember that in the sympathetic nervous system, you have a thoracolumbar distribution of the release of the neuron from the spinal cord. The cell body of these neurons is usually located in the brainstem, but it can also be located in the spinal cord. And these neurons are released from the spinal cord at the levels of the thoraco and lumbar spine. In the parasympathetic nervous system, you have a craniosacral distribution, meaning that the neurons are released from the central nervous system at the level of either the sacrum or the brainstem. And these neurons, such as cranial nerves 3, 7, 9, and 10, the vagus nerve, or cranial nerve 10 being the most important, they go on to innervate the entire body in terms of the parasympathetic nervous system. But the important thing to remember is that the nerve bodies will leave the central nervous system at either the level of the cranium, the cranial nerves, or the sacrum in terms of innervating the kidney, bladder, and sex organs. This is an overall diagram showing parasympathetic on the right. You'll go over this more in your neurophysiology lectures and neuroanatomy lectures. In general, when talking about adrenergic receptors, we can divide them up into alpha and beta receptors based on their structure, and also based upon the second messenger systems that they employ. Alpha receptors are then divided up into alpha-1 and alpha-2 receptors. Alpha-1 receptors are found in blood vessels mainly, and they, when activated, can cause vasoconstriction. They mainly are associated with G10 and G11, which activate phospholipase C. Alpha-2 receptors generally are associated with GI and GO, which are known to inhibit adenylyl cyclase and also inhibit calcium and potassium channels. This leads to decreased cyclic AMP production. Beta receptors are divided up into beta-1 and beta-2 receptors. Beta-2 receptors generally found in the lung. Beta-1 receptors are generally found in the heart. Beta-2 receptors are also found in skeletal muscle vasculature. These receptors generally are thought to stimulate GS, which stimulates adenylyl cyclase and calcium channels. Beta-3 receptor is generally found in adipose tissue and is responsible for a metabolic process. The concept of dominant tone is very important. In a certain organ system, you will have a dominant tone, and the dominant tone of that organ system can either be sympathetic or parasympathetic. And each tissue is different. Giving medications such as ganglion blockers, like hexamethonium, trimethophan, or mecamylamine, will have a certain effect on the tissue, and their effect on that tissue will allow you to determine whether the dominant tone in that tissue is sympathetic or parasympathetic. These medications, the ganglion blockers, will block nicotinic cholinergic receptors at the junction, generally thought to be in the ganglion, the place where the presynaptic and the postsynaptic neurons will touch each other. These medications are not used anymore, but they can still be on the USMLE. Hexamethonium is different than the other two in that it's a non-competitive inhibitor of the nicotinic cholinergic receptor. The effects of the ganglionic blockers will differ based on the tissue. For example, ganglion blockers will cause vasodilation. This means that in vasculature, you have a dominant sympathetic tone, because sympathetic tone causes vasoconstriction, and it's being blocked by the ganglion blocker. They'll also cause an increased heart rate, which means that at baseline, you have a dominant parasympathetic tone in terms of the sinoatrial node. They can also cause mydriasis, reduced GI motility, and urinary retention. And this is a summary slide that talks about what the dominant tone is in different types of tissues. In arterioles and veins, generally there's a sympathetic tone that's active. In the heart, the parasympathetic tone is active, as we already talked about. In the iris, generally, we have a parasympathetic tone that's always active, as well as the GI tract and the urinary bladder. This is why we see the effects that we do with the ganglion blockers. Some other medications that we'll talk about briefly here and get into more detail later are autonomic neurotransmitters. Dopamine and epinephrine fall into that category. Dopamine itself acts at the dopaminergic receptors D1 through 5, as well as beta-1 and alpha-1 receptors. Epinephrine is produced in the adrenal medulla, is transported into the bloodstream, and is responsible for activating most types of adrenergic receptors, beta and alpha receptors. Let's talk about acetylcholine receptors. Acetylcholine receptors are generally divided up into either the muscarinic or the nicotinic type. And these are named because they can also, besides binding acetylcholine, bind to either muscarine or nicotine. For muscarinic receptors, the prototypical foreign agonist is muscarine, which is derived from the mushroom. Acetylcholine is what's found actually in the human. Remember that muscarinic receptors are found on targets of parasympathetic innervation, and in general, the activation of these receptors slows down cardiovascular function, will increase secretions, and increase intestinal activity. There are 5 different muscarinic receptors, and they all have different functions. M1 through M5, and you can see their roles here, M1 being a neural type, M2 being cardiac, M3 being glandular and smooth muscle, M4 is also thought to be neural, and M5 we are unclear as to what its role is. The odd-numbered receptors act through the inositol triphosphate pathway, or IP3, whereas 2 and 4 are able to activate GI and inhibit adenylyl cyclase and reduce cyclic AMP concentrations. The nicotinic receptors have a prototypical foreign agonist known as a nicotine. But the endogenous agonist, again, is acetylcholine. These nicotinic receptors are found at many places, including the neuromuscular junction, which is found on the muscle cell itself. They're also found on autonomic preganglionic terminals, meaning that the receptor is found in the ganglion itself on the surface of the postganglionic neuron, as well as in the brain. In general, the effect of activating muscarinic receptors cause increased GI tract motility and secretion, increased bladder activity, and increased salivation and sweating. Some important muscarinic agonists include bethanechol, which is commonly given for treatment of urinary retention, and methacholine. Methacholine is used in diagnosis of asthma. It's not used clinically except for this purpose. The methacholine challenge is used during pulmonary function tests to initiate or elicit asthma symptoms in those patients. Patients that have attacks of acute glaucoma generally have a deficiency in the ability to drain aqueous humor out of the eye into the canal of Schlemm. In general, anything that causes the pupil to constrict will actually help the aqueous fluid drain out. This is why we give pilocarpine, which is a muscarinic agonist. It causes pupillary constriction and allows the canal of Schlemm to open up and allow the aqueous humor to drain out, which will decrease the intraocular pressure and improve the patient's glaucoma. This is a diagram that shows the canal of Schlemm here in the anterior compartment. And as you can tell, the aqueous humor, which is produced by the ciliary body, works its way through the iris and into the canal of Schlemm. When the iris is constricted, there's still a pathway for the aqueous humor to get out. And when the iris does constrict, this canal of Schlemm is able to actually dilate and allow the aqueous humor to drain out of the anterior compartment. Pilocarpine, again, activates the M3 receptor, and it causes opening of the canal of Schlemm. It can treat both open and closed-angle glaucoma. Some side effects include sweating, bronchospasm, bradycardia, and diarrhea, as you would guess from a muscarinic agonist. And other glaucoma drugs may include beta blockers such as timolol and prostaglandin analogs, both of which are designed to either increase outflow of aqueous humor or decrease the production of aqueous humor. Let's talk for a second about atropine. Atropine is produced from a plant called belladonna, or deadly nightshade, and it is a muscarinic antagonist. Atropine blocks the signaling on muscarinic receptors. In general, atropine in the hospital is used to treat bradycardia. So a patient that comes in has low blood pressure and has a heartbeat below 50, generally we will consider giving them atropine to speed up their heart. We can also give it as an antidote for organophosphate poisoning, and we can also give it to the eye in order to induce cycloplegia. If a patient has iridocyclitis, for example, it's very important to not make the muscles in the iris move, because every time they move, the patient feels extreme pain. This may also be important for ocular surgery. Remember the mnemonic that atropine makes you dry as a bone, red as a beet, hot as a pistol, blind as a bat, and mad as a hatter. These are because the multiple side effects of atropine can include decreased secretions, mydriasis, cycloplegia, hyperthermia, tachycardia, sedation, urinary retention, and they can also change your mood and behavior. And as atropine dose increases, you can see more and more side effects. The standard dose that we give patients that have bradycardia is 1 milligram. And as you can see, as you get up to 2 milligrams, you can see that the heart rate will actually increase. Whereas at the lower levels of atropine, it can cause cardiac slowing, mouth dryness, and so forth. Therefore, for atropine, it's important to give approximately 2 to 5 milligrams to see the heart rate improvement. Here's a list of clinically important muscarinic antagonists. You can see atropine here. Tropicamide is commonly given for ophthalmologic patients. Ipratropium and tiotropium are muscarinic antagonists that are given as an inhaled formulation for asthma and COPD. Tiotropium is a longer-acting formulation of ipratropium. Scopolamine is a muscarinic antagonist that is used to treat motion sickness. It can also be a sedative and an amnestic. Glycopyrrolate is commonly given for patients that have too much secretions coming out of their throat, especially in patients that are intubated. And benztropine is commonly given for patients that have some type of Parkinsonism, especially drug-induced Parkinsonism. Acetylcholinesterase, as you're aware, is an enzyme that degrades acetylcholine at both nicotinic and muscarinic synapses. Cholinesterase inhibitors increase the amount of acetylcholine that's present at the synaptic cleft. Those cholinesterase inhibitors include the following agents: neuromuscular reversal agents, drugs that are given for myasthenia gravis, and also some insecticides and nerve gases. Cholinesterase inhibitor poisoning can cause activation of both muscarinic and nicotinic receptors and can be fatal. This is why nerve gases are so potent. As I said before, cholinesterase inhibitors can maybe pesticides, insect spray, nerve gases. Remember that the effects of cholinesterase inhibitors result from activation of muscarinic and nicotinic receptors. Some important inhibitors that we see in the clinic are edrophonium, which is tensilon. The tensilon test is used to diagnose myasthenia gravis. Physostigmine is used for glaucoma treatment. Neostigmine and pyridostigmine are used for treatment of myasthenia gravis. And neostigmine is also used to reverse non-depolarizing neuromuscular blockers. This is a cartoon that shows the neuromuscular junction in myasthenia gravis. As you can see on the right, the patient with myasthenia gravis has loss of the acetylcholine receptor because of autoimmune damage. These patients require higher levels of acetylcholine in order to activate the muscle. Other important acetylcholinesterase inhibitors include donepezil, which is used to treat Alzheimer's disease, and also the classically tested organophosphates, which are the nerve gases and insecticides. Ecothiopate is actually an organophosphate that's used for treatment of glaucoma, but most organophosphates fall into the nerve gas and insecticide categories. The effects of acetylcholinesterase inhibitors through the muscarinic receptor activation include meiosis, decreased heart rate, bronchoconstriction, and increased secretion of glands. With regard to organophosphates, initially the binding of the organophosphate to the acetylcholinesterase can be reversed, but after a few hours it becomes irreversible. 2-PAM or pralidoxime can prevent irreversible binding if it's given early enough. 2-PAM actually reactivates the acetylcholinesterase enzyme. The toxicity of acetylcholinesterase inhibitors, such as organophosphate, falls under the mnemonic dumbbells: diarrhea, urination, meiosis, bronchoconstriction, CNS excitation, lacrimation, salivation, and sweating. The management of organophosphate poisoning, the most important thing is to remember your ABCs: airway, breathing, and circulation. Make sure the patient is able to get air into their lungs. If not, they need to be intubated. You can also give atropine and pralidoxime or 2-PAM. Many times these medications are given in combination with each other for military personnel that are entering areas where they may be exposed to nerve gases. This is the order for treatment of these patients on the boards: supportive care first, then atropine and 2-PAM. This is the final slide in this section. This concludes Autonomic Pharmacology 1. In the next section, we'll be talking about adrenergic signaling in the autonomic nervous system.